Meeting of Health and Public Housing.
This conference will now be recorded.
Just want to start off by doing a quick roll call if we can. So, Alan Cintron, are you here?
Wayne Rowe here.
Okay, Wayne's here. All right, great. Joe Fuentes?
Here.
All right, Joe. Len Lavender? Len, you here?
He's probably cannot hear us now.
Okay.
He might be in the process of.
Okay. Okay. I see. Saki, are you here?
Saki. Apologies on
I am.
Hey, Saki. Okay.
Hi.
And we know Vanessa's here. Okay. Okay, are we ready to go?
You ready to go?
All right. All right, folks. Well, listen, it's been a while since we got together. There are a number of things we want to cover, and I know everybody's time is short, and I know a lot of people are on vacation. It's a tough time of the year, but very happy that you guys are with us today. I'm going to start off by talking about HUD and Vision Centers. And before I proceed, I just want to ask, has anybody, or let me know if you have heard about Envision Centers at all. Anybody?
I think just to the previous call that y'all had, or that we had with them.
Okay, so we touched on it.
There's another call.
Okay.
I know I heard about from you guys. Didn't put it that way.
Okay. Okay. Well, since this thing basically kicked off in December, it's a program to really stimulate self-sufficiency for residents of public housing and those receiving housing choice voucher assistance from HUD. And it was announced by Secretary Carson from HUD back in December. They did a kickoff up in Detroit at the Boys and Girls Club there. And again, as part of the effort to help folks in their quest to be self-sufficient, self-reliant, be able to kind of take care of themselves and maybe move on from the system, so to speak. The idea is, economic empowerment, educational advancement, health and wellness, and character and leadership. And, our perspective is that this is really kind of a natural fit for public housing, primary care, and community health centers, because, of course, health and wellness has always been key to us. Economic empowerment, health centers have always been an economic engine for the communities they serve, hiring folks in, various support functions and in entry-level positions for the healthcare industry. Also, with that comes a lot of education, if nothing else, certainly health education, but a lot of health, training for employees and that kind of thing. And numerous health centers over time have had different courses in character and leadership. How to be a parent. How to be a good boyfriend, a good husband, a good wife, a good participant in society. Gang mitigation, efforts, all that kind of thing at various health centers around the country. But on the health and wellness side, they specifically note 3 goals. 2 out of the 3 actually mention FQHC. The first goal is to increase the number of prenatal visits. The second is to increase the number of adult physicals. And the third goal is to increase for preschoolers hearing and vision screenings. And, those are all things, obviously that we can do. But we're looking at this as an opportunity to make sure that more folks are getting primary care across the board. So we think this is a real positive thing, for the patients we serve. So we're kind of encouraged about it. Now, all that being said, this thing kicked off in Detroit, and it's taken a little while to really progress. We did some work, with the health centers and the housing agencies in Detroit. We've done some work here in DC, and I was down in North Carolina the last couple of days, dealing with the Envision Center down there. And they all present kind of unique challenges. In Detroit, you have actually 3 different locations. Two of them are, I guess, a traditional model. You've got a health center in close proximity to a housing agency, and that's the typical model. But they also have a third site, which is run by a nonprofit organization, and it's in a school given to this nonprofit organization, a group called Life Remodeled, and they've got a lot of space, but it's kind of in a sort of a no man's land between the catchment areas for different health centers in that area. And so we're actually still working to find out, if we can, do a new access point there, or somebody to do change in scope, or if it's going to be maybe more a mobile unit, or maybe it'll morph into something entirely different where there's a partnership between a health center and, say, the Ford Health System, which is very big in the Detroit area. Down in North Carolina, they have a much different situation. They've got a COG, a Council of Governments, which has 4 different housing agencies, and there are health centers in the area, 2 or 3 of them, but they're all probably about 45 minutes distance from the housing agencies. But everything there is pretty spread out. It's pretty rural. So there's going to be kind of a lot of work to figure out how that's going to work. They have picked out basically 17 different demonstration sites around the country. They're going to be in Texas, in Fort Worth, in Pennsylvania, in Philadelphia, in Oklahoma, Choctaw Nation, in Youngstown, Ohio, Grand Forks, North Dakota, Hickory, North Carolina, where I was the last couple of days, Phillipsburg, New Jersey, Kansas City, Missouri. The Michigan sites are 2 in Detroit and 1 in Inkster. In Kentucky, Bowling Green. In Kansas, Kansas City. In Illinois, Chicago. In D.C., well, there's one in D.C., and then Hartford, Connecticut, and San Diego, California. So this stuff is going to roll out slowly. One thing we're not certain of is how long the demonstration is going to be and how soon they want this to go nationwide. We know that Secretary Carson at HUD wants this to go national. I attended the HUD budget hearing back in April, May for the Senate, and I will say the senators were not very happy with the proposed cuts that they tried to make in CDBG and rental subsidies and disabled housing, all of which they rejected. But they all really liked the idea of Envision centers, and we're all strong proponents of it. And that was Republicans, Democrats on the committee, big states, little states, urban, rural. So I think it's something that can be very positive. It's just a question of getting it off the ground there. So all they've done at this point really is to identify the partners. People applied. They went through a selection process. They've done some kickoff meetings with the different partners, but now it's a matter of actually making this thing work. So that was something I want to get out to you guys. And let me just stop for a minute and see if does anybody have any questions on it, any curiosity, any interest, any suggestions. All is quiet. Okay. All right. Well, then we'll keep you.
So this is Joe. Sorry, I was trying to find my mute button. Yeah, the first model you mentioned, that's more of what we've been trying to do.
Yep.
And one of the private foundations down here is pushing, really pushing, or strongly advocates for the community center health home model, and they're similar in aspects. And so we chose not to do that one, but this one would be more in a way for also to tie more of our housing clients into primary care, because we do permanent supportive housing as well. And so, and we're the largest provider for that in Houston. And so we can't force people to take services, but this model may actually help us do a lot more MI and things of that nature to get them into primary care.
Okay. And so you said the community center home health model?
Yeah, which is pushed. So in Houston, the Pittsburgh Health Charities has funded this model for different organizations, and they're really into systems change. Most of the funders down here in terms of private foundations,
yeah,
that's their goal, is systems change. And they're pushing that model. However, they haven't seen another kind of model that can be used for housing. So housing is always not funded. It's always got to be a community health center. So this could be a collaborative that could actually be funded, because I believe there's no funding attached to this, correct?
There is no funding attached to this. You're absolutely right. Which
right. So
why
I would probably go to a private foundation and ask if they can give us some money, like just a planning grant, just to get it planned at least, and get buy-in that way. So presenting something like this to a private foundation source would be very beneficial, but it also ties in housing, which if they're funding health, they want to see how housing, they don't always buy the argument that for us, health is, that having housing is part of healthcare. So this will be a really good link to show them, even from HUD, that they're invested in healthcare and give us a chance to even get a planning grant to actually do this work.
Well, Joe, one thing you actually just reminded me of something. One thing that they're waiting for is to actually identify and officially announce their anchor partner. They've been talking about this anchor partner for months, and apparently we initially thought they were going to have a different anchor partner in each location, each of the 17 locations, and that's not the case. They're going to have one anchor partner nationally, and we understand that anchor partner is going to provide some of the, I guess I'll just say, management support, for this whole initiative. So we don't know who it is.
Okay.
In Detroit, we thought it was going to be the Ford Foundation or somebody like that. So they're trying. Hopefully, they're going to make the announcement within the next 2-3 weeks. At least that's kind of the indication we're getting. And then I think this is going to kind of kick off in a little higher gear. They've been trying to put this stuff together. They've been kind of building the airplane while they're flying it, and it's kind of slowed them down, I think, in general. And I just hope it all sticks together, because in terms of addressing the social determinants of health, it's really a good idea. Now, we wish they'd put some resources into it. They announced yesterday in one of the meetings we had that they've, I guess, put up about $2 million, which is directed toward this demonstration effort. And it's interesting, they're actually going to run this thing out of HUD, out of PD&R, which is basically their policy development and research arm. And there are some good people there, including the people who wrote the publication on HUD-assisted, health and all that kind of stuff. So we're kind of encouraged by that. And, we talked a lot yesterday about putting some kind of structure together and some kind of, manual, which they're kind of working on. Because the problem with a lot of this stuff is if it's all tied, say, to Carson, and say he decides he doesn't want to do this anymore in 2 years, you hate to see all the effort get blown up. So I think they're trying to institutionalize it and make it work. And like I said, they would like to do it everywhere. And I will say there were about 8 or 9 senators that were at the hearing, and every one of them said they wanted to envision centers in their state. And I know that a lot of them get them.
No, I think it would make sense. I mean, HUD and HRSA have done many grants together for homelessness. And so I don't see why HRSA couldn't do something with HUD. In terms of, even SPINs through Ryan White, through HAB and HRSA, have done those SPINs projects, which also, we have one right now. It's employment, housing, and Ryan White Part A primary care.
Yep.
So I just really can't understand how it's difficult, at least from the user perspective. I don't understand how it's difficult.
Yeah.
Because they're saying the same things. They're using different nice headings, but it's really the same thing. Social determinants, health, and QI really go hand in hand.
Yep.
And so for us, identifying finance and housing, it just happened to turn into a big service line. So, but we keep them separate lines of business because either one doesn't understand one another yet. So, it's possible we're doing some of this. Just having validated through the funding sources is great, and you can leverage that. So I guess I'm looking in terms of sustainability. First time I see something, there's no funding attached to it. I always think about sustainability. Well, so one way is to at least get a planning grant, and then hopefully have that sustainability through billing and other things. And housing providers don't always understand the billings of FQHC and how that works. And so having that manual, like you said, or something where the language is like a Rosetta Stone for each of us to have, because I always have to switch back and forth what terms I use for each different funding source. So I think it's doable. Again, HUD has HUD and SAMHSA have been doing this for quite some time.
Yep.
And HUD, HRSA, HAB, and SAMHSA have been doing this for quite some time. And the SPINS project is an example of those.
Well,
just putting it out there.
well, Joe, you bring up a really good point. And in fact, we talked a little bit about down there yesterday, and then Jose were talking about it, and I were talking about it a little bit yesterday. And that is the kicker with all this stuff is there's no funding, right? So, and a lot of these folks, like I mentioned, the Life Remodeled site in Detroit. The Life Remodeled site in Detroit is located in a former school which was given to this nonprofit organization by the city. And it's a beautiful building. It's about 150,000 square feet that they have available. It's got Head Start in it, and it's got a bunch of other programs and job training programs and all that kind of stuff. And a fellow who is the head of the nonprofit, I know, would love to have a health center there. But the reality is that we're not sure that that's workable because, are there, for example, are there enough folks there to really justify a new access point, for example? So,
right.
One of the things we're wondering is, and I really like your feedback, Joe, and the other folks on the phone. Should we reach out to Jim? What was that? Go ahead. I'm sorry. Did you hear something? I think is somebody trying to talk, or somebody they having a side conversation? Hello? Okay, so I'd like to get some feedback from you guys if you think we should reach out to Jim McCrae and just talk to them about potentially taking into consideration when they're funding a new access point or considering changes in scope or whatever, the notion that they would consider Envision centers, is in their evaluation.
This is just two more comments, Joe, and I'm sorry, I'll stop after that. But I mean, it's really up to in placing a clinic at any of the public health entities, not public health, public housing authorities, or even a housing provider that sticks and bricks. If they allow it to be open in the community, then it's doable in terms of, especially with the new interpretation of public housing primary care. So it's doable. And then also, I don't see why through the continuum of care leads, why it can't be a new project under HUD, because HUD does pay for it. That's a priority, but under supportive services, it can pay for behavioral health, mental health, substance abuse, and medical. It just can't be the majority of it, but it can at least help. What we use it for is we'll block time so there isn't an appointment, but you're paying for the provider time. Sometimes it works really well, sometimes it doesn't. We right size it, but it allows for those appointments to be open for just those particular individuals at those sites. So it can be doable under HUD too. So that's why that's why it's a little frustrating to hear this, because they know that somebody around there's got to know it can be done. That's all I'm going to say on either side, because it's allowable cost under HUD. It's also allowable cost in terms of course, primary care under the FQHC grant. So I think it's the housing provider that actually owns the facility has to agree to open it to the community. And if they are, then you can make your numbers. Or it's also the size of the complexes, or you do it for that housing provider's entire system, all their which requires to be mobile, or do you telehealth to do it?
Mm-hmm, mm-hmm. And one thing I will throw into the mix, and you talked about the definition, a lot of these sites or a lot of these agencies, and especially as you go more rural, are much more housing choice voucher providers than they are low-income public housing providers. And I think that's something else that we want to pass on to HRSA, because we for a long time, this whole issue about the definition and housing choice vouchers and included and all that stuff. I just think the reality is, and everybody knows it, the direction public housing's going, and I think the concern has to be for the patients and the residents, or the residents who have transitioned because the housing authority decided to sell off the properties, for low-income tax credit housing or something, and now they're providing vouchers to those residents to live in those same units. I just think it's something HRSA needs to hear.
It's a shame that they don't leverage the COC dollars either, because that's how we pay for rent and we get housing first vouchers through the Housing Authority, but we also through the COC get leasing dollars.
Yep.
And it makes no sense when you're doing master leasing, and you have let's say there's a 150 unit, we're leasing 55, 50 are through continuum of care, 5 are from the Housing Authority, but yet you can only serve your 50 and not the other 5 because it doesn't come with support services. It's ridiculous. So we serve everyone. We use patient income to do that.
Gotcha.
Patient revenue to do that. So, I mean, you don't want to segregate in a community, especially one that's close knit.
Okay.
And I think some of those definitions are a little bit antiquated.
And we completely agree with you. Anybody else any feedback? Because we're going to move on.
Yeah.
Go ahead.
Hello. This is Zara Marcellian.
Hey, Zara.
I'm from La Maestra Community Health Centers in San Diego. And this is really interesting to listen to your perspective. San Diego County finally went for the whole person care, and now it's gone for health homes through HUD.
Yep.
But, and you know, and we've been following it, all of these initiatives, because La Maestra has created over 30 years our own circle of care around the social determinants.
Yep.
So we do a lot, you know, and I'm still waiting for that collaboration, like you guys were talking about, you know, through HRSA and HUD. And we participated in some small, you know, programs before, like lead-based, finding lead in the blood and whatever,
yep.
and going
Yep.
into the neighborhoods promotionally. But, you know, really there has never been, here at our local level, you don't see the evidence of that desire to collaborate. So I think that what gets established at the national level, and everybody's excited and they love the idea, by the time it gets down to the local level, it's like gone. You can't even get people to answer the phone down here at the Housing Authority.
Yep.
You got to go find them. So, you know, it's like, how do you really ramp up a true initiative collaborative with, you know, with the partner missing?
Right.
And then the only other thing I wanted to say was that I think, you know, like NAC, National Association of Health Centers, is, I don't know if you've heard about the Prepare program.
Yep.
They launched, and so they're doing their piece about, you know, trying to collect information to put on the electronic health records around social determinants, which is cool. But, you know, here we're going to be collecting information for how much longer, and then what is everybody supposed to do with it when they find that there's not enough resources out there in the community to refer people to, which is what we've found years ago.
Yep.
So, you know, so I think that if we could kind of look at those next steps of where the needs are and try to anticipate those and bring solutions for when, you know, for when this information hits the world, we'll be really far ahead.
Yep. You know, Zara, let's follow up, you, me, and Jose, and talk about this, because we want to talk about San Diego in general with respect, because San Diego is one of the cities. So let's have a
That'd be great. Let's do it
on that. And because I will tell you that in North Carolina, you know, in fact, yesterday we had a partners meeting in North Carolina, and we had probably 40 different service organizations represented. You know, health, housing, workforce development, transportation, child care, you know, job training, job search, you know, kind of across the board. So, you know, it was a good thing, but a lot of people pointed out just what you just did, that, you know, at some point there's just not enough. You know, there aren't enough beds, there aren't enough counselors, there isn't enough room in the class, you know, whatever the issue is. So you have some really good points.
Yeah, well, I mean, housing alone is a 10-year wait here to find something.
Yep.
So, yeah.
That's a great point. Anybody else with a comment or a suggestion? Okay. All right. We're gonna move on to kind of public housing trends, and we're gonna jump right into smoke-free public housing. I'm just going to talk for a quick second, kind of overview, you know, with where we are, and then Saki is going to talk about some research that she's going to be heading up over the next you know, month and a half or so. Well, no, actually a couple of months, I guess, 2-3 months. So anyway, you all know about the smoke-free public housing cigarette ban or smoke-free ban, which went into effect officially on the 1st of August last week. It has been a big issue. You know, there are a lot of resources out there, CDC tips included, and Saki's going to talk a little bit about that in a minute. I think across the board, as we've looked at some of the numbers, we've been a little underwhelmed, I guess, from the response from the community health centers and from the public housing agencies as to the level of cooperation between the health centers and the housing agencies. Now, I think some of it may be a question about terminology, because I think probably the housing agencies and the health centers don't see themselves as the health centers as being responsible for implementation. But we kind of see this as an opportunity to support those residents and those patients and really take a shot at achieving cessation. And we've done a whole bunch of activity the last few months in terms of, you know, webinars and trying to, you know, identify best practices and all that. And we're going to do, I think, a best practices webinar with CDC sometime later on this summer, and with the National Council on Behavioral Health, I think, actually around September. But Saki, why don't you go ahead and kind of do an update on the data that we have so far and the data that you're going to try to put together over the next 2-3 months on CDC tips.
Sure, thanks, Bob. So why don't I just talk for a second about the CDC tips project that we're doing. As Bob mentioned, we're collaborating with the CDC Office on Smoking and Health to promote the use of the CDC tips from former smokers, smoking cessation materials. So we have a small amount of money to do a training and technical assistance for 3 to 5 health centers. So on August 15th, we're having this. So first of all, we invited all health centers that are located in or immediately accessible to participate in the webinar that will highlight the tips material and show everyone how to download the information, give best practices on using the different types of material that they have available, both for healthcare providers and for organizations that serve public housing residents. And then our piece is to identify 3 to 5 health centers and provide additional ongoing support. It's a 3-month project period. So we are planning on having, you know, at least 3 calls with them to kind of figure out what kind of resources they need and help them, you know, place the materials and use the materials wisely in their centers. And we're trying to evaluate the usefulness of the CDC tips in the health centers, and we will be looking at, as far as data goes, the number of smoking cessation services that were provided before and after the use of the CDC tips material, and the conversations going specifically for tobacco users, kind of doing a before and after. It's a 3-month project period, but we will probably do a follow-up at a later time to try and see if there have been any impact or increase in the number of cessation conversations that are going on with these health centers because of this new resources. So we're identifying the health centers based on some criteria. One is, you know, they have to be new to CDC tips, but then also trying to encourage health centers that are in places where there are high smoking prevalence rates and have some geographical diversity, et cetera, there. So the first kickoff call is on August 15th is when the webinar is, and then we'll probably announce our sites by the end of the month and then start the training and technical assistance, and it should wrap up in November of this year.
That sounds great, Doug. And I'm just like is anybody got anything going that they'd like to note that they're doing around smoking cessation or assisting a housing agency with smoke-free public housing? Anybody? Is everybody kind of just doing it kind of as they've always done it, or is anybody any special initiatives, any connection or interaction with the housing authority on the smoke-free public housing rule and how they're going to get it done, or how they're going to deal with residents who really need help in either controlling or stopping smoking?
This is Laura again. We just we are providing the support through health education, through going to sites and offering services, like mobily. We have mobile clinics and we do health fairs and health events. And a lot of times that involves some of the low-income housing, public housing.
Yep.
And it's next to schools, and we're in schools and so forth. So we do this as another form of, like a health education, outreach, activity, through the promotoras that we have.
Yep.
And the cultural liaisons. So we've added it through that model because that works best than having a standalone with, that just being the focus. You might not get a lot of people.
Gotcha. Are you talking to the people at the public housing agency, Zara, or are you just kind of doing it on their own, just trying to serve the residents or the voucher holders or whatever? But are you actually talking to
that's a long time relationship we've had, and what works best is with talking to the managers.
Yeah.
And if you get managers that are supportive, we have actually had meetings at the site, at the public housing site, and that really worked well. But it all depends on who the manager is and that relationship that we're able to build. We on the other side, of course, as a FQHC, we have to meet certain HEDIS measures, as you know, and so we're constantly trying to be innovative in how do we reach people? How is it through the school, working with the schools? Is it through the housing, working with the housing? Is it through their community-based ethnic groups?
Mm-hmm.
Do that through the churches. I mean, so this isn't really a new approach. This is what works for us with our population.
Yep. Gotcha. Anybody, anything else on smoke-free or smoking cessation? Wayne, how about you guys?
We're working with our public housing leadership group in providing education right now, as well as supporting them with getting the word out about smoke cessation.
Okay.
We've been doing that for quite some time.
Okay, great. And do you offer counseling?
Yes.
Yeah. And
yeah.
You do it on site, or do you refer them someplace else?
We do it on site.
Okay. And who's doing most of that counseling for you guys?
Well, we have our provider staff supporting that with the nursing staff. We also have our behavioral health staff.
Okay.
That also provides it.
Okay. Very, very good. Because I think people are really looking for, some best practices on this. And this is, people have been talking about this thing for, since January 16. Mm-hmm. So quite a while. But now it's just kicking off. And so, people are really looking to see what's working. Now, a lot of people went smoke-free some time ago, and there's some good information out there. But it's a little different in that now it's not a choice. And they've got to do it, and it's not just some of the buildings; it's all of the buildings, and it's everybody. So, if anybody has anything that they think is that they like to talk about or expound on, we'd be very interested in any of the best practices stuff. And we are going to, like I said, we're probably going to do a webinar, probably I think in September, with the National Council on Behavioral Health and some other folks on this very subject. So, if you see something that's working, or if you feel like there's something you'd like to offer, you'd like to participate in that, please let us know.
We also have a learning collaborative. So we are planning to have public housing agencies, some federal organizations, some of the housing stakeholders like CLAFA and all of these organizations, even CDC. So if we are about to send that information out, if anybody is interested in participating in these calls, let me know, send me an email, and then we are going to move forward with these conversations. I understand that some of the health centers are participating in some of the activities that we have, but this one in particular is going to include state and federal agencies. So if you are interested, let me know, and I will add your health center to the activity.
Okay. Anything else? The next item on the agenda is the Public Housing Task Force. You guys could just let us know how many of you folks are going to be at the task force meeting in Orlando? Anybody? Okay. These are the, if you look at the...
No, I plan on being there.
Okay.
So I keep trying to find my mute button. I'm on my iPhone.
I know, Joe. I say a lot of the most brilliant things while I've got the mute button on.
Right? It's terrible.
Yeah, I know. These are the topics, that we've identified for the task force meeting. As you know, probably from past attendance, we don't really get a lot of time during the session. We'll get the update from NAC, and we'll get some updates from the HRSA folks. But these were the items that we were going to touch on. Is there anything else, HUD Vision Centers, SmokeFree, opioid epidemic, trauma, childhood obesity? Are there other items that you think we should, bring to the attention of the other folks in the task force and the folks from HRSA who will be, at the meeting? I mean, we can certainly talk about, as we talked about the Envision Center stuff, just the whole notion of support and collaboration between HUD and HHS, and funding, and that kind of thing.
And yeah, this is Zara, sorry. And the whole, reemphasize the importance of social determinants, in the whole healthcare goal and well-being. And it's not just, how well HRSA and HUD get along and really collaborate down to the local level. It's also involving all of the organizations that community health centers and medical providers in general are not used to including in their patient care plan.
Yep.
It's a whole philosophy. I mean, it's going to have to be tons of training on this.
Yep. Yep. Well, it's interesting, Zara, because when we were at the session in North Carolina yesterday, I talked to some of the folks, even on the HUD side. Now they have a program, Family Self-Sufficiency. So Family Self-Sufficiency is designed for people who get, includes people who get housing choice vouchers as well as low income public housing. And then ROSS is occupant self-sufficiency, which is for residents of low-income public housing, traditional public housing. And asked them if they had kind of a referral, I kind of use the word system, but, checklist, whatever. But it was funny because, there were 3 or 4 people there from the same office, and they were all doing something a little bit differently. And it seemed to come down to, who they knew at the different organizations that they were partnering with, and they didn't really have a kind of an organized way of reaching out when somebody needed help, or at least not a systematic way of doing it. And it just seems like that's something that, in terms of interagency cooperation, that, if you sat down and you talk about social determinants of health, and you got somebody from each of the folks at the table and just identified even the categories of services needed, and just, I mean, to me, it's almost like a checklist, you're going to punch through and say, sure. And one of the things we talked about is, if you're going to have an annual meeting with your housing choice voucher holder or your resident, why not, make sure you bring up, you know, the health issue, because, you know, just to make sure you've got folks into healthcare, and like you're trying to get them into, you know, some kind of job search or job training, or if they need enabling services or whatever it is. But I'm sorry, go ahead, Tara.
Oh, yeah. You know, I think a lot of it is, you know, one, the funding. If there's some kind of funding, because like we were talking about health homes here, it's just around now, you know, specific at risk for chronic disease, homeless individuals who've already been admitted, you know, to the hospital, and helping them around these social determinants. That's a very small percentage of the bigger issue. And while it helps, and I'm glad, let's see how it turns out, I think that funding will bring these different sectors within our communities together to even have the dialogue and go through some of those assumptions and the way that everybody's kind of been siloed. And, you know, I mean, we've seen it for years. Because we have to keep establishing pathways across these sectors, these bridges, so that we can not only get people in for services that we don't provide, but then follow them, do the case management. How are you going to prove outcomes if they don't share information with you? So these are some of the practical aspects that will, I think, you know, really make the difference as to who stays at the table and why.
Yep, that's a great point. And it's funny because, you know, we did an exercise yesterday, and there were probably 40 different groups in one of the sessions, and we basically identified, you know, we had everybody kind of stand in a large area, and it was like, well, how many of you work with, you know, health organizations, and then how many of you work with social service organizations, and then how many of you have not worked? And there were a whole bunch of people who had not. And then, but the next question was, would you like to? And the answer on almost all cases was yes, but they just weren't in the habit of doing it. Like I said, they worked with the usual suspects.
Because of that silo, the silo effect. It goes from DC all the way down. And I know because of projects that we were doing, I went to Arizona actually, to provide that very assistance to hook up the public housing, behavioral health services that couldn't seem to get their residents into the FQHCs. Well, I know what's going to convince the FQHCs, hey, you know, there's a whole pot of population here that's in your catchment area, and maybe you can get a, you know, expansion grant or whatever. And they assign somebody like right away. So it's not like people aren't interested. No, it's that they're not used to reaching out of their sector to finish the jobs for their clients or patients.
Yeah, this is Joe. I agree with that statement. I mean, if you're looking for value-based care, one of the ways to do that is with integrated practice unit, which is basically the CCHH model and this Envision Center. So that's the frustration I get. I mean, there is not one funding source that pays for everything. You have to glue it all together. It's like a jigsaw puzzle. So that's what we have to do. And then patient revenues help pay for the things that the grants don't cover. And so that's how we've been able to really address some of these miraculously. But some funding sources, like let's say Ryan White, if I had those resources for every chronic disease, we would be sitting pretty, and so would patients. We just don't have it. So we have to tackle one at a time. And we can't be all things to all people either. Maybe we're experts at 4 things and only if we start moving through this process. And the other health centers are collaborators with other health centers. Maybe they're good at another different 4. And we're just going to have to start really working together, being smarter, because once you start doing it, you see the redundancies. You also see the inefficiencies. And if someone else is funded to do them, hopefully they're doing a great job. You bring them into this integrated practice unit or the CCHH model or the Envision Center. So it's just really interesting to hear the conversations up there when I agree, we've been discussing these things for years.
And you know, it's interesting, at the end of the task force meeting in March at PNI, we talked with Tanya and the rest of the crew from HRSA just about the whole funding issue and Medicaid reimbursements and if they could do anything about that. So I think it's really you're bringing up some great points, and I think it's something that we should really hit on with them on this, because there's a lot of confusion even amongst, you're dealing with HUD, or you're dealing with the health agencies and the social service agencies. For example, the stuff that's funded by the Centers for Supportive Housing and all those kinds of programs that you guys are involved with, and there are a lot of folks who aren't quite sure where one begins and the other ends, and they're not sure about the different funding sources. Like they know there's money out there, but there's a lot of confusion about what is the appropriate funding vehicle and the appropriate grant vehicle for them for a particular problem, and who should be the lead and all that kind of stuff. And there may be something out there, and I know NAC does do like they do their, what do they call it? I forget it, but it's the conference that's in Las Vegas, which focuses on finance. And I don't know if it addresses this kind of thing, or if it's really more about the kind of the nitty gritty of financing a health center and reporting to.
Yeah, that's what it is. That's what it is. It's the nitty gritty only for health centers.
Yeah.
And that's what you're in.
Okay. So it's not really the integrated kind of thing we're talking about. So maybe that's something we could discuss.
Never.
Okay, we'll put that on. Okay, that sounds great. Okay, let's see, we're getting a little, okay, public housing. Okay, real quick, I think we may have talked last time a little bit about the HUD budget, but initially HUD, proposed a budget that was going to be about a 22 to 24% cut in the HUD budget, including wiping out CDBG, about reducing the number of vouchers, about 250,000 vouchers they were talking about getting rid of. About a 10% cut in the tenant subsidy funding, reduction in disability, even housing for the disabled. It wasn't a small cut because there's not that much money in it to begin with. I think it was like 27 million. But fortunately, and as I mentioned, I did attend the budget hearing in May, at least the Senate hearing, and the senators were not very positive about the cuts. And essentially, by the way, these are the same cuts, except a little more extreme, that they proposed last year, and the House and Senate rejected. So at this point, it looks like the money is back in. And in fact, for example, on Envision centers, which we talked about earlier, which initially had nothing, it looks like they've got about $2 million allocated for that. So I don't think there's going to be a lot of additional money, but there is not the big reductions, which would have been really kind of traumatic if they had really happened. So, if anybody, any comments on that, or any questions? So I think I would say we're pretty much status quo in terms of the number of vouchers and the number of tenant-based rental subsidy that's out there.
This is Joe again. Can I make a comment real quick? I'm sorry, I got a lot of comments about this.
Yeah, go ahead.
So, for example, we have 3 large COC grants, and one of the things that we always have difficulty doing is we get better every year, but there's still a lot of money left in leasing, and it's client leasing for our clients in permanent supportive housing. So that money has to go back, because it depends on we try to do our best, number of units, then the size of the units, the kind, and every year as a whole, the program in general, we always return money back.
Like what percentage?
And you hope that money comes back to the COC, but you also hope it comes back to you in a way.
Yeah.
Well, what do they do? Sometimes they still do it, and they increase it sometimes, and because the fair market rates increase. Well, if we're doing a better job in terms of finding apartments that are more affordable, we can serve more people, which we did. It's just the leasing dollars didn't follow that, because maybe there were more SROs this year, or more one-bedroom units where people were in need, because we rely on coordinated access now. Yep. And so those funds can then be unallocated or go back to another project, or can be used or for a new project. And that's why I'm having a real hard time. I mean, yes, level funding, I get that, but in theory, or in practice, I should say, money gets returned all the time, not just by us, but other grantees. Yep. Or other subcontractors. And so to repurpose that money to help fund these Envision centers, or why can't an Envision center be part of a new project in the COC continuum? Yeah. I mean, that's just a simple question for HUD. I mean, if they really want it, they're already funding it in certain ways anyway. Why? It's no, I guess I don't see it as any difference when you go in with the premise that not one grant's going to fund your entire program.
What percentage of your funding goes back, Joe? Do you return?
So we had like almost $3 million in leasing, about $1 million went back.
Wow. Okay, a third.
And it's because we either find more, you know, the population shifts. So we have about 1,700 clients in permanent supportive housing with 1,200 units right now.
Okay.
And so we served more people, but the cost of the leasing went down. But that's on the market. That can be anything. Fair market rates go up. We have to wait for those to kick in. You know, there's always this transitionary period. And so, but with our 1115 waiver that we have here, because the state didn't take Medicaid expansion, that grant's going to end in the year. And where are those people going to go? You know, in terms of, because the housing authority issues those vouchers for that particular program. And there are people in that.
If we might want to do a follow-up conversation, because I mean, I think probably you have maybe the greatest understanding of the housing financing part of this. If we wanted to try to structure a discussion around an interagency, you know, funding, you know, working group or something, you know, I like to pull you in. And Zara, do you do the supportive housing as well?
Yes.
Yes, we do. We do supportive housing services.
Okay.
To, you know, and we're trying to expand on those, of course. Yeah.
Okay. Anybody else interested in kind of the interagency finance stuff? Wayne or Alan? Len? Guys?
And maybe it could be structured around how to fund an Envision Center. I mean, if that's really the focus, because again, the health center program is important in that. It's even on their model.
Yep.
So I mean,
yeah, that's right.
You know, so it's just really, if we're being held to those things, I mean, HUD does pay for support services, but it's only 20% of your grant.
Right.
Right. I think if we want to capture more eventually players at the table, organizations, we should just leave it at, you know, not one specific model, even though we can suggest that. But I mean, I think just to get us to the table around and building those interrelated, connected ties, collaborations, that's the big point.
No, I agree with you. That's a good idea.
Okay. All right. Well, we'll try to put something together on that in the next couple of weeks. And I know that people, you know, it's the end of the summer and people are trying to get that last couple of days off kind of thing. So maybe right after Labor Day, if that's practical for folks. But we'll send out a doodle or whatever it is, noodle schnoodle, and try to find some dates that work for people. Okay. The last item we want to talk about is just the symposium. We had hoped to actually do it kind of, we were trying to piggyback on the NAC meeting, but due to some logistical and you know, issues around registration, of which apparently was broken and we didn't know it was broken until it was too late to do anything about it. It just became too late to really fix it, and so we're trying to reschedule. We may go next year with the actual same hotel, and we will know that. We're supposed to know that by the middle of next week. If not, we're going to kind of open it up again. And if anybody has any suggestions on anything that they would think might be either a great location or a great format, you know, we did a regional in Chicago about a year and a half ago, and really liked it, and really liked the second day portion, which was at the Miles Square Center in Chicago. We had some great participation from some of the folks from the health center and from the University of Illinois Medical School. And just the environment I thought was really conducive to some of the discussions we had. And I'm just wondering if anybody out there has a partnership with anybody who, you know, thinks that they could actually do kind of a larger conference. You know, could we do something in partnership with the university or a health center, you know, in a facility that's not a hotel, that would accommodate, you know, a couple hundred people, you know, 250 people, and just want to kind of get some quick feedback on that. Any thoughts? Any things that you've always wanted to do at a conference or a training symposium?
You know, this is Laura. I wish I had creative suggestions on that. I do not.
Okay. But I appreciate that response. That's okay. That's very clear. Okay. Anybody else? Joe?
I'm actually kind of dumbfounded on that one. I mean, you know what I like about the symposium that I'll have, that it's smaller in terms of more one-on-one time. So those smaller sessions, I seem to get more out of when I go to the larger one. And it's not because I like one or the other the best. It's the fact that they're smaller sessions. And so I think anything around innovation I always think is great. And that can be in terms of technology, service delivery, evidence-based practices, how even EBIs or some of these DEBIs or whatever we want to call them, how they're tailored in different areas. Like and the one that just comes to mind is our HIV prevention projects for the South. That's funded under NACHO and also under the SPINS grant. And so those kind of things are somewhat tailored to the South, where we have to rely on the East Coast and West Coast. And so those homegrown interventions have really become ones that we've chosen and tried to adapt and tailor to our populations. So anything in terms of innovation, I think would be great.
Okay. And when you talk about the smaller sessions, are you saying an overall a smaller conference, or are you saying smaller breakouts? Or
breakouts, yeah. The smaller breakouts, like limited number, because everybody can attend and there's no room to sit, and there's always one topic that everybody wants to go to and it's packed, or like myself, I'll have a lot of questions and then don't realize I'm asking so many questions, and then later on get the look, you know. So maybe it's a special session for people like me in the special class. Just sit there.
Well, you know, it's interesting because when we did Chicago, we did most of it in actually we had the entire group together, and I thought the plus of it was we got kind of all different perspectives on it, and I thought we got a good level of participation, for the group that was there. But at the same time, you're right. Maybe there is. I don't know what the right balance is between kind of a large plenary group and what we did at that session was, we had a couple of microphones and people running around with it, and I thought we had pretty good participation from the group. Nobody was, by the end of it, nobody was shy, and it's not a very bashful group anyway, to tell you the truth. So everybody was kind of right in there pitching, on some of the different issues we had discussed. But I think you're right, though. We probably need to kind of give some thought to where the smaller breakout sessions are more advantageous, I guess, to everybody involved. So, and
there's also a limited number of people, so you can't always attend all of them. Because sometimes you schedule they're at the same time, so you have to go to half of one and then hope you hear it. Yeah. And while the presentations, everything on the on the website and stuff, it's just the fact of not hearing it firsthand.
Yeah. I got you. Okay, that sounds good. And I think we're just about out of time. So does anybody have anything that we haven't touched on and they've been dying to kind of get out to the group? Anybody? Going once, twice, 3 times. Okay. All right, folks. Thank you very much. Really appreciate it. We'll follow up, on the couple of issues that we discussed around the interagency collaboration and finance, and around Envision centers and so on. And again, as the smoke-free implementation goes on, if you have some great suggestions, we'd be interested. And then look for Saki's note or about the webinar on the 15th around CDC tips utilization. All right, guys. Thanks a lot.
Can we get a copy? Can we get a copy of your slides so I can use for my board presentation?
Yep.
All right. Thanks.
Sure. Yep. You can get that.
Great. Thanks, y'all.
Thank you. Thank you very much.
All right. Take care, guys.
Bye.
Bye-bye.
Okay. Bye-bye.